Morning from me. I would like first of all to thank the organizing committee, especially Prof. Kotsis, for the kind invitation. Coronavirus infection is a global pandemic with 59 million patients worldwide and 1.4 million deaths. It is an acute complex systemic disorder that in severe cases presents with interstitial pneumonia, progressing to acute respiratory distress syndrome, and multi-organ sepsis and multi-organ failure. 30 to 4% of infected individuals are asymptomatic. Of those who develop symptoms, 81% are mild, 14% are moderate, 5% develop intense endothelial activation, cytokine release syndrome, ARDS, and multi-organ failure. The overall case fatality rate is 2.3%. The incidence of thrombotic events in corona patients is from 7.7 to 49%, and this is significantly higher than in patients without corona. The mortality rate in patients with venous thromboembolism and corona varies from 8 to 26%. Venous thromboembolism is the most prominent manifestation of coagulopathy, almost 7 times more frequent than arterial thrombosis. Patients are predominantly male with diabetes mellitus, hypertension, and cardiovascular diseases with a history of prior venous thromboembolic event in 3 to 5% of them. The more frequent manifestations are pulmonary embolism, deep vein thrombosis, catheter thrombosis, clotting in the continuous replacement therapy or in extracorporeal membrane oxygenation machines, and infrequent manifestations are myocardial infarction, stroke, peripheral arterial embolism, splenic infarcts, and aortic thrombosis. Venous thromboembolism in corona patients increases the risk of death by 3 times above the normal level, while bleeding manifestations are low. The pathophysiology of thromboembolism in corona infection is multifactorial. Corona infection it is well known that it is a hypercoagulable state, a combination between thrombosis and inflammation. The mechanism of activation of coagulation includes the downregulation of angiotensin-converting enzyme 2, which promotes vasoconstriction, platelet aggregation, and reduces the fibrinolytic activation. Furthermore, the overproduction of pro-inflammatory cytokines induces vascular permeability and activates coagulation pathways, while corona induces also pyroptosis, which is a highly inflammatory form of regulated cell death. Also, the presence of extramedullary megakaryocytes is a unique phenomenon of corona and plays an important role in the increase of the thrombotic risk. Neutrophil extracellular traps link inflammation, coagulation, and thrombosis, and their levels correlate with disease severity. Endotheliitis leads to activation of tissue factor and platelets, and also corona has effects on the myocardium, such as acute myocardial injury, stress cardiomyopathy, cardiac arrhythmias, and pericardial effusion. But all corona patients are not the same. Parameters such as hospitalization, BMI more than 30, risk factors for venous or arterial thromboembolism, and high-flow nasal oxygen or mechanical ventilation categorize corona patients into 4 groups: low risk, intermediate risk, high, and very high risk. So, risk assessment is recommended in all hospitalized patients with corona according Padua, Improve, or Caprini model. Obesity, hypertension, diabetes mellitus, male gender, increased fibrinogen and D-dimers, thrombocytopenia, antithropin decrease, lymphopenia, and a compensated Dick-East score 5 or more than 5 are significant risk factors for worsening disease. We have to perform a screening test for venous thromboembolism if we have clinical indications despite of D-dimer elevation. We have to administer parenteral anticoagulation because of its shorter half-life, the ability to be given intravenous or subcutaneous, and fewer known drug-drug interactions in every hospitalized patient with corona, except those with clear contraindication. The intensity of anticoagulation therapy depends on the severity of the disease. In hospitalized patients who need therapeutic anticoagulation, we have to monitor frequently renal and hepatic function, and also we have to evaluate drug-drug interactions between antithrombotics and co-administered anti-corona medication. As we can see, DOACs and antagonists of vitamin K have many interactions with medications of corona, such as anakinra, hydroxychloroquine, lopinavir, ritonavir, and tocilizumab. Heparin has anti-inflammatory and antiviral properties, but there are also in vitro data that heparin may interact with the spike protein of corona and inhibit corona cell invasion. So, in every hospitalized patient, we have to give thromboprophylaxis with low molecular weight heparin or unfractionated heparin, which cause 20% mortality decrease, especially in patients with D-dimers more than 6 times the upper level. In possible or confirmed heparin-induced thrombocytopenia, we can administer fondaparinux or argatroban or danaparoid or bivalirudin. There are contraindications of anticoagulation, such as active bleeding, the acquired or hereditary serious bleeding diathesis, possibility of lumbar puncture or epidural anesthesia, a number of platelets below 25,000, uncontrolled serious systolic arterial hypertension, and acute serious ischemic stroke during the first 48 hours. In all these cases, we can consider mechanical thromboprophylaxis and increased mobility. We have to avoid DOACs and antagonists of vitamin K because of many drug-drug interactions, because of possible renal or hepatic failure, when there is need for invasive procedures, and because there is not universal access to antidotes. For patients under oral anticoagulants, we have to replace them with parenteral anticoagulation. This is the most important picture with regard the anticoagulation algorithm in corona hospitalized patients. So, if we have a patient, a corona positive patient, who is in the intensive care unit, who has a high suspicion of venous thromboembolic event, or who is has a high thromboembolic risk, we have to administer therapeutic doses of low molecular weight heparin, for example, enoxaparin, 1 milligram per kilogram every 12 hours. If he is hospitalized in the intensive care unit, but he does not have a venous thromboembolic event and he is not a high thromboembolic risk patient, we have to administer low molecular weight heparin in intermediate dose, for example, enoxaparin, 1 milligram per kilogram every 24 hours. If we have a patient who is not hospitalized in the intensive care unit, but he has high thromboembolic risk, then we have to administer intermediate dose of low molecular weight heparin. And at last, if we have a patient who is not in the intensive care unit and he does not have a high thromboembolic risk, we have to administer prophylactic dose of low molecular weight heparin, for example, enoxaparin, 40 milligrams every 24 hours. Of course, the dosage of the anticoagulant regimens depends on the glomerular filtration rate and on the BMI of the patient. If we have a corona hospitalized patient, we can predict overt disseminated intravascular coagulopathy according to the compensated Dick-East score, which depends on the positivity of corona infection, on the platelet count, the prothrombin time prolongation, D-dimers, antithrombin activity, and protein C. if the compensated DICT score is 5 or more than 5, then we have an overt disseminated intravascular coagulopathy, and we have to manage this situation. What about corona patients post-discharge? In patients at high risk of venous thromboembolism, if the bleeding risk is low, we have to administer extended prophylaxis, either with either low molecular weight heparin or DOACs, for example, rivaroxaban, 10 milligrams once a day. The duration of post-discharge prophylaxis should be at least for 14 days up to 30 days, and for high-risk patients up to 3 months. Patients at risk for post-discharge venous thromboembolism are those with cancer, previous venous thromboembolic event, D-dimer more than 2 times the upper level of normal, age more than 75 years, admission to the intensive care unit, or history of thrombophilia. For patients who are already receiving anticoagulant or antiplatelet therapies, when they become COVID positive, we should continue these therapies after the corona positivity. We have to pay attention to drug-drug interactions because clopidogrel and ticagrelor are contraindicated while prasugrel can be used. When we have patients who are under antiplatelet therapy and become corona positive, we have to estimate bleeding and thrombotic risk and take under consideration drug-drug interactions. In patients under single antiplatelet agent, we have to consider to add prophylactic anticoagulation if there is no contraindication. In patients under dual antiplatelet agent, we have to replace one of the antiplatelets with prophylactic anticoagulation in those without stent or with no recent stent implantation if there is no contraindication. We have to add prophylactic anticoagulation in patients with recent stent implantation, and we have to modify the dual antiplatelet agent therapy according to the number of platelets. If we have platelets more than 50,000, we continue the dual antiplatelet agents. If they are between 25 and 50,000, we have to halt one of the antiplatelets, and if they are below 25,000, we have to halt both the antiplatelet agents. What about corona positivity and myocardial injury, arterial thrombosis? When we have non-STEMI patients, we have to administer parenteral antiplatelet and anticoagulant therapies. When we have STEMI patients, the primary percutaneous intervention is the standard care strategy if there is no contraindication. Parenteral antiplatelet therapies have no drug-drug interaction with corona treatment, while TPA or streptokinase can be used. If we have acute limb ischemia, we have to administer prolonged course of anticoagulation, and if the patient has acute ischemic stroke, intravenous thrombolysis maybe is contraindicated in severe corona coagulopathy because it increases post-thrombolysis mortality and morbidity. If the patient is already treated with thrombolysis or endovascular therapy, antiplatelet therapy should be avoided. For corona-positive outpatients, we have to evaluate thrombotic risk according to Padua or IMPROVE score, and we have to encourage increased mobility. In outpatients with high thromboembolic risk, without bleeding risk, we have to administer anticoagulation prophylaxis for 1 to 2 weeks with low molecular weight heparin or DOACs, such as rivaroxaban, 10 milligrams once a day. In outpatients already taking antithrombotics, they should continue their treatment. All these are recommendations according to expert panels such as AS 2021, IST 2020, NICE, and NHS 2021. So, in conclusion, all corona patients are in increased thrombotic risk. Thromboprophylaxis in all hospitalized corona patients should be administered, except those in high bleeding risk. we have to administer at least intermediate dosage of anticoagulation in high-risk patients who are hospitalized in intensive care units. We have to consider extended prophylaxis post-discharge in high venous thromboembolic risk patients and prophylaxis in high venous thromboembolic risk outpatients. Up till now, there are no proven indications for add-on antiplatelet drugs, and we are waiting for the final results of many trials with regard to the therapeutic dosage for moderate state hospitalized corona-positive patients. Thank you very much.